Yeah. This is your boy Abraham Tutorials. Kindly subscribe to my YouTube channel, Tutorials Abraham. So today I want to talk about constipation. Constipation. So this is a very common topic, but I want to discuss what it is, causes, management. So constipation is basically a digestive problem characterized by infrequent bowel movement or passing to stools. So what are the causes of constipation? So basically, uh, we can one of the causes is called dietary factors. So dietary causes. So another dietary, so if you take low fiber intake and also insufficient food intake, so insufficient food intake. So the second aspect is constipation can be caused by medications. Example, maybe pain relievers such as opioids, e.g. morphine, oxycodone, etc. And also there's some anti-acids, especially those anti-acid, especially those containing aluminium or calcium can cause. And also antidepressants, drug used to manage depression, antidepressants such as tricyclic antidepressant, example amitriptyline, okay, call that. And also selective serotonin reuptake inhibitors such as sertraline, fluoxetine, yes, even paroxetine can cause and then the other cause, we can say medical conditions such as irritable bowel syndrome, hypothyroidism, diabetes, and then and certain neurological disorders such as multiple sclerosis and then Parkinson's disease. And the other cause, you can say lifestyle factors such as lack of exercise, and then ignoring the urge to have a bowel movement. So you are pressed and then you don't want to go to the toilet, ignoring the urge to defecate. So actually this is very common in children, especially, for example, when they start school. Sometimes they feel shy to go to the toilet and then they audit. As a result, water can be reabsorbed from the colon back to the other part of the gastrointestinal tract, making the stools to harden, leading to constipation. And then we can say maybe other factors or miscellaneous factors, pregnancy, and then changes in daily routines. So let's quickly go to what you call pathophysiology. How does constipation occur? So stools move too slowly through the large intestine, so decrease bowel movement. So what happens? Through the large intestine colon, leading to excessive water absorption, resulting in dry skin. So as a result, water is reabsorbed back into the other parts of gastrointestinal tract, leading to constipation. So, for example, I also like to talk, how does pregnancy cause constipation? How does pregnancy cause constipation? So what happens that we know that during pregnancy, there's high production of a certain hormone called progesterone to maintain the pregnancy. So the intestines, high levels of progesterone in pregnancy can relax the intestines, so can cause relaxation of the intestine, and then making it harder for them to squeeze waste out of the body. This in turn allows the body to absorb more water and nutrients. So there's absorption of more water and nutrients. So yeah, yes, from food, which can make stool more solid and difficult to pass. And then the other aspect is pressure. So there's pressure as the pregnancy progresses. Yep, the growing uterus can put pressure on the intestines, making it harder to move stool. So the growing uterus can put the pressure on the intestine, making it difficult for them to, to push stools. And then other causes of constipation in pregnancy, that during pregnancy, women are given prenatal vitamins, and minerals. For example, they're commonly given ferrous sulfate for prophylaxis of microcytic anemia, which is basically, you can say, iron deficiency anemia. So this ferrous can cause constipation. What are the common clinical presentation, that is signs and symptoms. So we have straining during defecation or passing out of stool, straining. We also have a feeling that not all stools have passed. Yep, a feeling that Not all stools of pasty. What else? A feeling that the rectum is blocked. Rectum is blocked. And then there's what we call general discomfort. And then hard, dry, or lumpy stools. So stools can be hard, dry, yep, and lumpy stools. Yep. So how do we manage now or treat? How do we manage? So you can say treatment. The first approach is non-pharmacological. So without the use of drugs. So lifestyle changes. So you can say increase exercise, physical exercise. So you can establish a regular bowel routine. Like in the morning, you can go to the toilet, and then the second part we say dietary modifications. So eat foods containing high levels of fibers. Yep, fibers such as fruits, vegetables, or popcorns, or whole grains. Talking about popcorns, I think for another year. And then increase intake of water. At least 2 liters, even to 3 liters in a day, possible. And then for those who ignore the age to defecate, especially children, you can counsel them, and then address barriers. If they are shy, talk to them that they shouldn't. So going to pharmacological management. So we give drugs known as laxatives and purgatives. So laxative gently facilitate bowel movement by softening the stools or increasing its bulk. So these they basically soften the stool, soften stools. Soften the stools and also increasing the bulk. And then purgatives, rapidly increase the bowels, often more aggressively, leading to intestinal. Leading to intense and rapid bowel movement. So this is basically cleans the bowels, leading to rapid intestinal bowel movement. So what are the types? Number one, we have what we call bulk forming laxatives, e.g. we have psyllium, which is also known as the aspergillus ask. So this is given as 1 teaspoon, which is basically, you can say, is equivalent to about 5 grams. And then you dissolve this in 8 ounces, equivalent to 240 ml. Yep. And then you can give, after dissolving, the person can drink maybe 1 to 3 times a day. Yep. So how do they work? So this basically, they absorb water in the intestine, increasing stool bulk and triggering bowel movement. So they absorb water and then increase bulk of stools. So this now will increase bowel movement. And then the other example of bulk forming is methylcellulose. So methylcellulose is given as 1 tablespoon, usually you can say 2 grams. And then you dissolve it as well in 8 ounces, which is equivalent to 140 ml. And then 1 to 3 times a day as well. Yep. So the second group of drug, we call them stool softeners. Example, we have deoxysate sodium. So this can be given between 50 to 300 milligram in divided doses. So out of it, to increase the amount of water the stools absorbed in the gut, making it softer and easier to pass. So they draw water from other parts, so increase amount of water. The stool absorbs and then softening and leading to softening of stools. Yep. So deoxysate sodium, we also have deoxysate calcium. We also have deoxysate potassium. And then the other examples is polyethylene glycol. Common known as PEG3350. Yep. So this is given a 17 gram, dissolved in between 4 ounces to 8 ounces, that is 120 ml to 240 ml once daily. And also we have mineral oil. So it can be given as an enema. So introduce oil. So enema is a medical procedure in which liquid is introduced into the rectum and colon through anus for constipation relief. So they can give 15 to 45 ml per oral, or can give us 118 ml rectally through the anus. And then other example under softeners, we have glycerin. Yep. So this it can give in form of suppositories. suppositories. So maybe 1 suppository per day. As a group of drugs, we call them osmotic laxatives. Commonly use these ones. So they draw water into the bone from surrounding tissues, softening stools and increasing bowel movement and frequency. So this basically draw water. So they basically draw water into the bowel from surrounding tissues. Yep. Causing softening and increasing frequency. So this, they also softens the stools and also increasing frequency of defecation. So what are the examples? You have polyethylene glycol, commonly known as Milalax. So yep, so basically 17 gram, so which is equivalent to a heaping teaspoon dissolved in 4 oz to 8 oz. Yep, once per day. And then we have lactulose, commonly given to prevent even opioid-induced constipation. Can be given 15 to 45 mils once a day, or even up to twice a day. We also have magnesium. We also have magnesium hydroxide. So the common brand is milk of magnesia. So you can be given between 30 to 60 mils once a day. And then the other group is a stimulant laxative. So this is basically stimulate the lining of the intestine, increasing muscle contraction to move stool through the bowel. So this is a stimulate. They stimulate the lining of intestine and then increase muscle contraction, increase muscle contraction, and then the result, increase bowel movement. So common example, bisacodyl, known as Ducolax. So it's given between 5 to 15 milligram, usually knocked during the night, because it takes about, it should be 8 hours for it to give results. Or it can also be given as 10 milligram as suppositories to insert in the anus. And also another example is Senna, commonly known as Senocot. So usually given between 8.6 to 17.2 milligram once a day. And then it can also be given up to 34.4 milligram BD as needed, basically for short-term use for constipation and bowel preparation. And then we also have another group is called saline laxatives. A good example is magnesium citrate, given as 240 ml once a day. So this is the draw water into the intestine through osmosis, inducing bowel. So osmosis is applied here. We also have sodium phosphate. 1 enema bottle are directed. So 180 mils. And then we also have what is called the lubricant laxatives. Coat the stool and the intestinal tract with waterproof film, keeping moisture in the stool. Yep. So they coat the stool. And the intestinal tract with waterproof film, keeping moisture into the stool. We'll go to mineral oil, given between 15 to 45 mils oral once a day, or 118 mils rectal as needed. And then chloride channel activators. Chloride channel activators. Chloride channel activators. So activate chloride channels in the intestine, increasing fluid secretion and improving bowel movement. So this they activates chloride channel, and then in the intestine, increasing fluid secretion. The result is increase food secretion, and then it's improving bowel movement. So a good example is the lupiprostone. Lupiprostone, given as a 24 microgram BD with food. Yep. And then this is usually for chronic idiopathic constipation, irritable bowel syndrome with constipation. And then another group, you can say guanylate cyclase agonist. So these are basically increased fluid circulation in the intestinal, accelerating transit time. So a good example is the linaclotide. So given as 145 microgram, common known as the license chronic idiopathic constipation, common used. And then the last group, which is called 5-HT4 receptors agonist. So these are basically enhance gastrointestinal motility by stimulating serotonin receptors in the intestine. So they basically stimulate serotonin. Yep. So a good example is the prucalopride, common known as motegrity. So it can be given as 2 milligram once daily, used in chronic idiopathic constipation. So as I conclude, So most stimulant and osmotic laxative should be used short term due to potential side effect and risk of dependence. So stimulant laxative, example bisacodyl, and then osmotics like lactose should be given short term because they may cause dependence. Long-term use, you can prefer back-forming laxatives, stool softeners, and certain prescription medication such as procalopride or linaclotide. Thank you so much. May God bless you. Subscribe to my channel.